Thank you, everyone, for joining us today. I'm Brenda Talent, CEO of the Show Me Institute. For those of you who don't know us, the Show Me Institute is an independent research and education organization. We focus on Missouri fiscal and economic policies from a free market lens. And one of the policy areas that we focus on is healthcare. So we're very pleased to host this event today. In the past year, governors across our nation have issued a number of executive orders in reaction to the pandemic. Many of these center on increasing access to healthcare. Today, our panel is going to discuss why those orders should become permanent. I want to get a little bit of housekeeping out of the way before we begin. We will be taking questions at the end of the presentation. So if you look at the bottom of your Zoom screen, you're going to see a Q&A box. Click on that and submit your question. Zach Longhorn of the Show Me Opportunity will be moderating our discussion today. To kick our program off, I want to introduce our first speaker. Patrick Ishmael is the Director of Government Accountability here at the Show Me Institute. In that role, he's tasked not only with promoting transparency in government, but in continuing his longstanding work in other policy areas, especially in healthcare. For nearly a decade now, Patrick has provided testimony, spoken publicly, and written in outlets across the country on the importance of promoting greater supplies of healthcare through free market reform. He works out of our Kansas City office, and of course, he's an invaluable member of our team. So Patrick, I'm going to turn the program over to you.
Thank you, Brenda, and good morning and good afternoon to our friends around the country on the call today. One of the revelations of the coronavirus pandemic has been how important online town halls like this can be to the public interest. And today we have three national experts with us to share their knowledge about how healthcare has changed so far in this crisis and where we should go from here. This event couldn't come at a more pivotal time for Americans as we look to make permanent changes to our healthcare system and to ensure that healthcare is affordable and accessible, pandemic or not. Our guests, Josh Archambault, Naomi Lopez, and Ray Hederman, will address three key reform areas directly: telehealth, scope of practice, and health insurance. But all could speak about far more than just those topics. So if you have health policy questions that may not have been specifically covered by the end of these presentations, please feel free to ask those questions during the Q&A period. Now, before I get too far ahead of myself, let me introduce our first speaker. Josh Archambault is a senior fellow at the Foundation for Government Accountability, where he focuses on healthcare policy. Josh also served as a health policy fellow at the Heritage Foundation and holds a master in public policy from Harvard's Kennedy School of Government. He's also a Patriots fan, which might also make him a Tom Brady fan, but because Missourians are very open-minded, I won't hold either of those positions against him today. Josh will give his insights into telehealth, and Show Me Opportunities Director of Communications, Zach Longhorn, will moderate the remainder of today's conversation. So Josh, thank you for joining us. The floor is yours.
Thank you so much, Patrick, and I really appreciate the invitation. Perhaps it is a little too soon to talk about football. Maybe we need a few more months before we return to that. So let's stick with healthcare for today. What I wanted to do on telehealth is three things. One, I wanted to talk about what is telehealth. The second is what has the state done during COVID? And the third is where should it go? And so I'm going to start with the one that might seem the simplest. I think COVID has really accelerated the public's familiarity with what they think telehealth is and how to use it. Perhaps many of you have had a chance to use it or a family member. But I think what folks don't realize is there's actually a few different forms of telehealth. So I wanted to highlight those. So the one we might be most familiar with is actually basically what we're doing right now. You're talking to a provider over video or with audio, but there are other kinds of telehealth. So there's something called store and forward, which is sending health information that is considered a form of telehealth. And then there is also something called remote patient monitoring. And so let me just give an example of that. So you may have somebody who has diabetes in which a provider wants to more regularly monitor their blood sugar levels. And so they may have some sort of machine at their home in which they're able to test blood sugar levels, and that information is then automatically sent off to a provider. That is a form of remote patient monitoring, and really, I think, going to become a lot more common going forward as technology becomes cheaper and cheaper, and as medical providers see them as part of their kind of care plans, if you will. And that all can fit under telehealth. So I just wanted to highlight there's a diversity of kinds of telehealth and how it is utilized. And I think we're going to see more and more of it beyond just these video chats that some of us are seeing on the news or have experienced ourselves. So let's talk for just 1 second about the benefits of telehealth. Some are very, I think, self-evident. It can be very convenient. It can also help you not have to go into a room full of sick people. That is another benefit, especially mindful folks with chronic conditions or elderly that want to just make sure they can touch base with a provider without having to expose themselves to others that may have other symptoms of things that they don't want to catch. I think it certainly can be much more efficient. We hear of providers who are able to practice telehealth from their home office. They don't have to go into a hospital or another facility to be able to have patients pop up right in front of them. And they can see more patients over a period of time or see them in the evenings or on the weekends. I think another big benefit is it kind of ends geographic discrimination of who you can see for providers. You're able to see providers that don't live in your community. They may live across town, they may live across the state, or they may live in another state, which we're going to talk a little bit more about going forward. But the final benefit I wanted to highlight is one that folks don't typically think about, but there's a big move in medicine towards more team-based care. So trying to get multiple providers, specifically for those that have chronic conditions, on the same page. So you're having an appointment at the same time with 3 or 4 providers. Again, diabetes is a good example of this, where you may have a primary care doctor, you may have an endocrinologist, you may have a nutritionist. You may want to get them all together with the patient at one time to be able to maximize the efficiency, but also the care plan. And telehealth allows you to do that in a way that in-person visits just simply don't. It's a lot harder to schedule that way or to even have all of those providers in your community. And I think telehealth, the future of telehealth, is going to allow for more of those kinds of innovations. Final thing on kind of what is telehealth, just want to talk briefly about who it can benefit. I think the short answer is everybody. But in particular, when we have looked at kind of the public polling and asked people in focus groups, they are very focused on the benefits to those with chronic conditions, those that live in rural communities, those with disabilities. Those are the folks in particular that policymakers and others should be very aware of who this benefits the most. That's kind of an overview of what is telehealth. So let's talk briefly about what the state has done during COVID. And there has been some really good movement. The governor did issue executive orders relatively early in the pandemic that did a couple key things. And one was it waived the requirement that a provider had to have a Missouri license to see patients in Missouri. So it was allowing more providers to be able to be available to patients if they chose to go that direction. Nobody was forcing them to use telehealth. It was just a new option for them. It also allowed for providers to pay for more out-of-network telehealth. The state has some interesting laws around insurers can restrict who they pay for telehealth, and that waived that requirement. It also gave some flexibility around prescribing certain drugs. All very good flexibilities. But executive orders expire when it comes to public health emergencies. And so it's very important, as Patrick mentioned, to be digging into this issue, to be looking at what can the state do going forward to make sure that when those public health emergencies expire, those that have gotten used to telehealth and have seen the benefits and conveniences are able to use those going forward. So wanted to kind of wrap up by talking about kind of where should the state go from here. I think there's a few things that I would highlight is really important for the state to look at given the current state laws. The first is across state line care. We want to make sure that the state makes it permanent going forward that patients can have the choice to see a provider in their community, across town, across the state, or in another state. And I think this is important for a variety of reasons, whether it's a second opinion or whether it's seeing an expert that simply doesn't live anywhere near them. And it needs to be explicit in state law that this is allowed, and it needs to be a relatively easy process. We want to make sure that there aren't these artificial barriers that make it exceedingly difficult for providers to be able to see these patients. The other thing I should mention is this matters if the state wants to attract people to live there. If they move, they still may want to see that some of their providers who have known them for a couple of decades. So they may want to come to the state for the quality of life, but they may want to stay in touch with their providers. And this sort of law framework makes that more possible. We want to make sure we remove those barriers. The other one I wanted to touch on is that the state does have some mandates around telehealth currently. Now, telehealth really is game changing when it comes to things like telestroke and other sorts of services, but the research is a little bit more mixed for other kinds of telehealth. And so when the state steps forward and mandates that insurance company has to pay for everything, whether the research supports it as efficient or not, or effective or not, there should be some concern. The other issue is around payment. And I'm sure we're going to hear a little bit more about payment issues because often in healthcare, that's where the sticking points are. The state requires that providers are paid the same for a telehealth visit as an in-person office visit. Now, the concern with this is a couple aspects to that. One is we know that a lot of patients actually avoid care out of fears of the high cost of care. So that gets cemented when you have a payment mandate. The other one is it cements in a lot of price variation that is unwarranted to facilities that do not deliver higher quality care for higher costs. And so we are cementing that in by requiring them to be paid the same amount of money. And the final thing I'd mention is around team-based care. When you have a system that largely pays one way, a fee for service, if for every service that's paid, you pay the same way, it's very difficult when you mandate payment parity under payment parity laws to move towards more innovative models like team-based care. And so there are some deep concerns there that if not adjusted going forward, that patients in the state won't be able to access those innovative care models as easily. The other thing I'll just mention, I think there's been a wide acknowledgement that patients and providers should be able to establish relationships over telehealth versus having to see each other in person first. So making that very clear in state law that is okay to do when it's medically okay to do that. The other thing that should be considered is allowing flexibility for what kinds of technology can be used. So right now in Missouri law, it's clear that they want HIPAA compliant, federally compliant technologies to be used. And while that's understandable, when you have certain communities in which broadband is not as easily accessible, but smartphones are, we want to make sure that both the provider and the patient have the flexibility with consent to use the technology that's available and right for them and not erect these artificial barriers going forward. So again, we talked a little bit about what is telehealth and how it looks different in different varieties. We talked a little bit about what the state has done and wrapped up by talking a little bit about where the state should go. We're really optimistic about the potential here, and we hope that policymakers in the state are able to make this permanent.
Great, thank you, Josh. I want to remind all of our viewers to submit your questions using the Q&A box at the bottom of your screen. Next up, we have Naomi Lopez Bauman. She is the Director of Healthcare Policy for the Goldwater Institute, where her work focuses on a broad range of healthcare issues, including the right to try, off-label communications, pharmaceutical drug pricing, supply-side healthcare reforms, the Affordable Care Act, Medicaid, and 21st century healthcare innovation. Naomi, I'll turn it over to you.
Thank you so much for having me today. I want to point out right off the bat that I am a proud native Texan, and I actually live in Springfield, Illinois, just about 100 miles north of St. Louis. So I really value being able to cheer for NFL teams whose quarterbacks wear real boots and not Uggs. So in talking to a friend of mine recently, I'm helping her and her husband find the best quality care for what could be kind of a rare set of symptoms. And like I said, we're in Springfield, Illinois, and I can tell you that in our research in trying to find him the right physician, we are over and over coming up with facilities in St. Louis, and this is not uncommon. For those of us in the middle of Illinois, we often will look to Chicago or St. Louis, and St. Louis, I think is probably quite a bit more convenient for most folks around here. And so I think it's really important to point out that Missouri has world-class healthcare. And the reason that this is so important is that you've got healthcare that's the best in the world for those who can access facilities like the Children's Hospital, like Barnes, like WashU, like Mercy. But when it comes to those patients who are perhaps in rural areas or who may not have the more serious diseases and illnesses, access and affordability are critically important. You've got to make sure that you're not shutting the door on access for the rest of the patients, for those patients who are with you 365 days out of the year, and not those that are just coming in as medical tourists to take advantage of your world-class healthcare. So today I've been asked to talk about something called scope of practice. So scope of practice are laws that dictate at the state level how doctors, nurses, pharmacists, and other healthcare practitioners may care for and treat patients. These laws vary widely from state to state, and they also needlessly prevent healthcare professionals from helping patients, even those who are trained and competent to do so. I am happy to say that Missouri has taken a leading role in several areas in this particular healthcare reform space. For example, allowing unmatched doctors to train in rural areas to become licensed in the state is an incredibly important reform. And you've also recently enacted HB 2046, which is a licensing reciprocity law. We passed this in Arizona a couple of years ago, which simply allows, just acknowledges that if someone moves into your state, that they don't lose all their skills and training just by virtue of crossing a state border. And Missouri enacted a very similar reform that allows people to come in and continue practicing whenever they're in good standing and they've got a certain amount of time under their belt and meet other certain requirements. So the regulated medical professionals usually include, but aren't limited to, physician assistants, nurse practitioners, certified registered nurse anesthetists, respiratory therapists, registered nurses, nursing assistants, dental hygienists, pharmacists, optometrists, paramedics. So the list goes on and on. But the really important thing to know is that state lawmakers have the authority and responsibility to make sure that these professionals are practicing at the top of their education and training. Too often, these professionals are limited in the services that they can provide, and it's not to protect patient safety, unfortunately, but to prevent legitimate economic competition between providers. And the result is that to increase cost of care by forcing consumers to pay higher prices than they otherwise would. The reason this issue is under such strong focus right now is because back in January of 2020, at the very beginning of the pandemic, then Secretary Azar issued a public health emergency, which allowed for the Department of Health and Human Services at the federal level to issue federal flexibilities for things like scope of practice. And this covered Medicare, Medicaid, the state children's health insurance program. And then that allowed states all over the country, and in fact, almost every state did this, to relax their rules around scope of practice. That meant that physicians, that nurses, for example, could level up and do more, despite what the state law says, because they were under either an Emergency Management Act as a result of COVID, or there was an executive order issued. In addition, some states were allowing providers to come in from out of state and practice in their state. They were taking initiatives like protecting for liability, and in addition, in some areas, they were also allowing those who are about to graduate from medical training to actually practice early, to begin practicing to assist in the COVID efforts. And what we know as a result of this happening all over the country is that there really wasn't a public safety threat. What we know is that care was delivered effectively, and we did not see some kind of large increase or jump in accidents or in lower quality of care due to the relaxed standards around scope of practice. So allowing medical professionals to practice at the top of their education and training has been a great policy during COVID, but it's something that should be made permanent. It's something that's good policy, and COVID should be good. It is good policy all the time, and that's why state lawmakers in Missouri should continue to build upon these reforms. And I'd like to just share a quick story about certified registered nurse anesthetists. These are the nurses that have very highly specialized education and training that goes well beyond a registered nurse certification. Usually they have graduate education. They're the ones that deal with anesthesia, they intubate patients and the like. and they also ventilate patients. And so what we know that is during COVID, there's already a shortage of anesthesiologists in rural areas, and that was only made worse by COVID. And that kind of care is often necessary for the most severe COVID patients. And so as a result of these important reforms that Arizona undertook in terms of expanding the scope of certified registered nurse anesthetists, allowing them to practice without an anesthesiologist in that same building, we were able to, in Arizona, provide much better care, particularly in rural areas, which helped with hospital capacity and getting those severe patients the care that they needed when they needed it. And so these reforms, I think it's really important to point out, like I said, you can have the best medicine in the world, but you can't neglect your rural areas. And it's these types of reforms, like we saw in COVID-19, that are really important for the rural areas where there's already a severe shortage of highly specialized providers, or really all providers who have the education and training to provide the most essential healthcare functions. And I'm looking forward to the questions. And I do want to let you know that the Goldwater Institute back last summer published a toolkit for COVID-19 and making policies permanent. And I will share a link to that in the chat. Thank you.
Great, thank you, Naomi. And another reminder to everyone, get those questions in, submitted using the Q&A box at the bottom of your screen. Next, we'll hear from Ray. Ray Hederman is the Executive Director of the Economic Research Center and Vice President of Policy at the Buckeye Institute, where he oversees their research and policy output. Ray has written extensively about returning healthcare power to the states, the impact of policy changes on the state's economy, labor markets, and how to reform tax systems to spur economic growth. Ray,
Right.
the floor is yours.
Thank you. So thank you to my friends at Show Me Institute for giving me this opportunity to talk about healthcare. We have a real opportunity in front of us. I don't have any Tom Brady references, except for the fact that maybe Cleveland Browns fans are the only people who thought 2020 was a good year, as they actually made it to the playoffs. But I think, if you think about health insurance market reforms, we've already been talking about those with my prior panelists. Because what health insurance is, it's a way to bundle together against risk and how to pay for healthcare costs. What Josh and Naomi have been talking about are ways to drive down the cost of delivering healthcare. When you go talk to businesses, you talk to business owners, everybody from small business to members of the chambers of commerce, you ask them what they worry about. Right now it's the pandemic, but usually healthcare costs is in their top three. How do we control the cost of health insurance premiums? And quite frankly, the easy answer, the one that we look towards, is increasing competition between insurance companies and between providers. What telehealth does, what scope of practice does, is makes healthcare more affordable by opening up the supply of doctors, nurses, dentists, into your local health insurance market. And that is a key component of driving down health insurance premiums. So let's take a look at what's going on in kind of the health insurance markets. As a reminder, before the Affordable Care Act, Obamacare, states had the main responsibility of regulating their healthcare markets. And we saw a lot of experimentation across the states. A state where Josh resides, Massachusetts, had very high state premiums because Massachusetts offered a lot of regulations and mandates on their state insurance markets. Ohio, where the Buckeye Institute is, by contrast, did not. So you much prefer to be buying your insurance in Ohio because it was more affordable. The ACA established national mandates of what a minimum insurance could be, and as a result, premiums skyrocketed. Since then, we've seen a change in uninsurance rates where younger people who are no longer subsidized in the ACA, are more likely to be insured. On the other hand, other people have been able to get highly subsidized insurance, but always far below expectations. That's one of the reasons why the Biden administration right now is trying to give out billions of dollars more to insurance companies to make insurance more highly subsidized. This is something that, is a federal issue, but states need to be aware of, because it's another step forward to government-controlled healthcare if we continue to highly subsidize people in the insurance market to buy more expensive healthcare. As Josh mentioned, I think, the first rule state policymakers should think about is often the first rule of medicine, which is do no harm. And harm in this case is enacting regulations and mandates that drive up the cost of healthcare, which drives up insurance premiums. Examples of this would be during the time of COVID, having to cover special types of family leave or emergency leave, payment parity at telehealth. All these mandates result in higher insurance costs because insurers have to pay for it and they have less bargaining power with providers. Even worse, we've seen some states requiring insurers to waive costs of COVID treatment. This is happening at the state level. Has the federal government said, COVID testing needs to be waived. But if you're forcing insurers to waive co-pays, for example, or limiting the amount that they could restrict beneficiaries for paying COVID treatment, that lessens the bargaining ability for insurers to talk to hospitals and their networks about what is the most effective treatment option for COVID. It encourages patients to go to their closest provider, which again drives up costs to insurance companies, which will one of the ways will drive up premiums. So Missouri has not enacted any of these laws. And so I would caution you to be on the lookout for these that seem well-intentioned, but instead add more mandates and drive up the cost of insurance. The second type of mandate that we've seen are any willing provider laws. These are laws that require insurers to include basically anybody who wants to offer a health insurance coverage in their network, and they have to cover them. So for example, we've seen a lot of people volunteering to act as treatment centers to be able to deliver shots. If these get included, these could be a dangerous precedent for expanding any willing provider, which again, lessens the ability of insurance companies to control cost, to find out who is a higher quality hospital, a higher quality doctor, for example, and this could drive up healthcare costs. President Trump's administration released a report highlighting the dangers of any willing provider practices and saying this is something that is in the regulatory authority of states. States need to be on the lookout for these type of practices, has increasing costs. And that is, again, something that the state of Missouri should take a look at. And the Trump administration also said that because of these practices restricting competition, they may use federal trust authority to look at the aspects of monopoly pricing there. So the other aspect, again, is what we're seeing. A lot of insurance companies have responded to COVID by waiving voluntarily treatment costs for COVID. While some of the states have mandated it, you have seen people saying that we're going to waive it, anything from out-of-network costs to waiving total costs, even if you're in network, waiving co-pays, waiving any type of hospital co-payment cost-sharing provisions for treatment of COVID. It's important to note that this is voluntary that certain insurance companies are doing and not being put into mandated law by government practice. Because it's voluntary, you're basically seeing insurance companies competing with themselves as a way to attract more customers. This is the market competition we work. It's a good way for people to be able to look and say, this insurance company is offering me a better deal. Maybe I'll go to this one. It's a good way to drive down premiums. This is not the what you want to see if the government is mandating where all insurance companies have to offer the same type of benefit. As a result, you will see cost increase as they have less negotiating ability with some healthcare providers and hospitals. So I want to just again emphasize, I think, that one of the biggest things that we see driving down a possibility for lower insurance premiums, as Josh mentioned, is telehealth. Unfortunately, we're seeing in some states that provisions are being snuck in that would require payment parity or would require people to go in person to doctors. This defeats the benefits of telehealth. Josh talked a lot about benefits to patients. There's a huge benefit in terms of healthcare economics that telehealth can be done cheaper, quicker, allow doctors to see more patients. You can actually use telehealth, I think, to start bending parts of the cost curve of healthcare. And again, these are the type of reforms that drive down premiums. If you're then mandating, however, that an insurance company cannot take advantage of cheaper provider practices who maybe don't need the infrastructure and they're having to pay the same amount as an in-person visit or you're mandating you must see your provider in person, that defeats the cost savings approach, and insurance premiums will not go down as a result. The other aspect, again, for telehealth driving down health insurance premiums is allowing second opinions across state lines. So, for example, if you are somebody who wants to see a cancer specialist in California, a doctor, a medical provider who specializes in this type of services and is more cost effective, insurance companies can be able to partner with these type of networks to deliver better costs for their healthcare companies. Insurance companies want to keep their customers healthy because obviously that means lower costs to the insurer companies. So finally, I want to shift to proactive, a proactive plan that we're seeing. And that is the ability, continued ability in Missouri to effectively utilize short-term health insurance plans. So as you know, we saw a huge spike in unemployment rates last spring as many companies completely shut down. Unfortunately, many industries have not fully recovered, where workers are still experiencing furloughs and layoffs. Not every worker was able to, keep their insurance during these layoffs, and as a result, we've seen congressional action. We've seen plans opening up special enrollment during the ACA, and we've seen Congress saying, "Look, let's try to subsidize COBRA." But what the market has offered is a solution known as short-term health insurance plans. Short-term health insurance plans are insurance benefits that basically are not subject to federal law or can be up to 6 months in the state of Missouri and can be renewed. And the goal of these plans is to help people find healthcare coverage for a time such as a pandemic. Maybe you have a change in your job situation. Maybe you've temporarily lost employment, and maybe you're looking for an alternative healthcare system than a more expensive COBRA option. What short-term plans do is give people a bridge utilizing a private insurance to be able to get to the insurance they may need in a more permanent situation. And because short-term plans are not subject to the mandates of Obamacare, they're they're much more cheaper. Economic research has seen that premiums are anywhere from 50 to 70%. And one study I saw in Missouri showed that short-term plan premiums are closer to 70% cheaper than a comparable plan on the ACA exchange. And so the short-term plans are offering a solution for these workers that were maybe temporarily unemployed as a result of the pandemic. So for example, we have seen one short-term plan be able to say, we saw an enrollment increase of 165%, with about 9 out of 10 of those enrollees were previously uninsured. So the short-term plans is another market innovation and solution to lower the uninsured rate by making health care and health insurance more affordable. Finally, let me just note that the Biden administration, I think, may take a look at reversing the Trump administration actions that made short-term plans more available to individuals. And so it's important that Missouri take actions to make short-term plans attractive to as many possible consumers as possible. That can go from anything to making short-term benefits basically transparent. So somebody's enrolling, they know up front what the benefit plans cover and do not cover. As I said, short-term plans are not subject to the same mandates of the ACA. So it's important consumers know, for example, that a short-term plan may not cover any pre-existing conditions. If you make this information available, we're seeing high customer satisfaction from short-term plans. And in fact, a lot of these short-term plans responded positively in light of COVID by offering similar treatment, COVID options being waived, co-pays being waived, has more full insurance plans, year-round insurance plans that are subject to the ACA mandates. So the short-term plan options are a good off-ramp that states can control. States have the ability to regulate. And I encourage Missouri to continue to make these options affordable and allow people to make informed consumer options and give them the option to enroll, specifically those that have been disenrolled from insurance plans. Finally, let me note that right now, the reason this is a critical time that we need to act, make a lot of these ideas permanent. is because the alternative, as we're seeing pushed out of Washington, is permanent expansion of Medicaid, permanent expansion of the ACA enrollees. So for example, we're seeing right now that, again, the Biden administration is looking at, jumping up, making Medicaid more attractive to states that haven't expanded, boosted the match rate that the federal government pays to states in a way to encourage more people on Medicaid. This can be harder to get them unenrolled, especially because the Trump administration made a lot of great healthcare reforms, such as telehealth. Medicaid now offers a telehealth benefit at the federal level. And unless states act to make telehealth permanent in the private insurance market, you're going to be faced with a situation where Medicaid, a government program, offers a richer benefits on telehealth than some private insurance companies that may be forced by state regulations to have all sorts of disincentives to utilize the telehealth service. So it's important, if we want to get people off government health care, that we act to make private insurance as flexible as possible. And that means using all our tools like telehealth, short-term plans to control health insurance premiums. So Zach, with that, I'll turn it back over to you.
Great, thank you. And I'll remind everyone watching again to please submit your questions using the Q&A box. Naomi, I'll start with you. Everyone feel free to jump in after the initial question. Naomi, have scope of practice restrictions played any role in the vaccine rollout that we're currently in the middle of, restricting those that can administer the vaccine and the like?
Yes, so during COVID-19, we know that the federal government took steps to encourage states to allow pharmacists broader scope. And we know a lot of states did do that, where they were allowing pharmacists and pharmacy techs to engage in the vaccine effort. But there's something really important that state lawmakers and policymakers need to understand about the pharmacy scope issue as it relates to COVID, as well as other immunizations. We know that during the COVID crisis, immunization rates are declining for a number of reasons. People are staying at home, for example. People are avoiding medical settings, and kids aren't in traditional school, which is one way that you help promote vaccination. And so with the increase in people not getting their regularly scheduled vaccines, in addition to the heightened demand of needing people that are qualified and trained to vaccinate, there's been a lot of attention on pharmacists. So pharmacists, I think for at least the past 15, 17 years or so, graduate pharmacy school with the education and training to vaccinate. That's just a universal requirement to graduate from pharmacy school now. And so we've got a workforce that's already educated and trained, but what we have in place in a lot of states are rules and regulations that, for example, will say that a pharmacist can vaccinate a CDC recommended vaccine. Well, a CDC recommended vaccine is an additional layer of required approval above an FDA recommended vaccine. You can even say an FDA, that they can issue an FDA approved vaccine, but keep in mind that the COVID vaccines are approved conditionally under emergency use authorization. So it's not really an FDA approved vaccine. So we really have these laws at the state level that don't necessarily align with the reality of vaccines and the way that they're approved and the way that they're deployed. And so I think it's really important for state lawmakers to go back, look at their state rules as they pertain specifically to vaccinations, as well as other treatments. For example, pharmacists are very knowledgeable in running a strep test, for example, and issuing and prescribing an antibiotic for strep. Same with ear infections. And so there are a lot of very simple primary care type services that pharmacists could easily do. And think about what it would mean for a patient. If you're a single mother who works, you may not be able to take off 3 hours of your day to take your kids into the office to get a very quick diagnosis that might be a lot cheaper at the pharmacy than at your physician's office. And so there are a lot of different areas where pharmacy scope is very important, not only in COVID-19, but also afterwards, for not just COVID vaccines, but other primary routine healthcare, as well as as well as other vaccines that may not be legally allowed under state law. And let's keep in mind too, that pharmacists have an enormous wealth of knowledge when it comes to maintenance medications. And we know, like, for example, in Arizona, we have in one of our executive orders that pharmacists can renew up to 180 days for maintenance medication. So if you need blood pressure medication, birth control, cholesterol medicine, during the pandemic, that you can easily get that renewed. And so the idea that pharmacists can write prescriptions is also really important to look at when we talk about the low risk type drugs, where you don't necessarily need anything beyond a self-evaluation that's shared with the pharmacist.
Hey, Zach, if I could chime in on that too.
Absolutely.
We call that in Ohio basically enabling pharmacists to test and treat. And so we're looking at similar legislation, and I encourage Missouri to make sure that pharmacists can be empowered to be able to test for some of those minor illnesses, everything from strep to flu. COVID is one that we're taking a look at, and then be able to prescribe treatment as well. Those are the type of things, again, that can be cheaper because a lot of these nurses, a lot of these pharmacists have the ability to more effectively administer a cheap strep test than sometimes having to go wait in a brick and mortar primary care provider. So this is a good way, again, to lower healthcare costs in your state by utilizing the ability of pharmacists to treat. And then, you also on the cutting edge, as Josh probably, might talk about, is that there's also telepharmacy as well, which is utilizing technology, again, to drive down the cost of acquiring drugs.
Right. So Josh, one of the impacts of the pandemic was this rapid adoption of remote work and Zoom conferences and telemedicine. So do you think that there have been any growing pains that we've experienced with that rapid adoption, fraud, exposing holes in broadband internet, and what are some things that we should be looking to do to fill in those gaps?
Sure. Yeah. I mean, it was interesting. I've talked to a handful of CEOs of telehealth companies, and for them to say, we effectively had a 3,000% increase in demand overnight. And that has continued to grow for many of them. Of course, there's going to be some growing pains for them, just from an internal standpoint. Do they have enough server space? Do they have enough customer service representatives to deal with providers trying to utilize the services and running into problems? So I think by and large, of course, we are far enough, unfortunately, into this that a lot of those kinks have been worked out. But on the policy side, there definitely has been some continued conversations. First and foremost, this conversation got the most ink in the headlines around Medicare in DC, because there were some severe restrictions around what Medicare or Medicaid paid for when it came to telehealth, and the commercial market sometimes follows those debates very closely and mirrors them. And so when the Trump administration and folks serving at CMS made some decisions to add some more flexibility, then there certainly was a change. And I think we saw a big spike in utilization of those services. I think it started to come down as things have started to open up a little bit more. But there certainly have been questions now about fraud and abuse. I think that there's a couple things for us to keep in mind. Our healthcare system largely is still a fee-for-service system. Again, providers get paid, or systems get paid for every interaction. Well, if you have a technology that makes those a lot easier to have those interactions, then you could understand if there was a bad apple before, it's now you've made it easier for a bad apple. And in particular for Medicare, and I'll put this on DC because of their policies around how they've set up pay and chase around bills. But I think this is an issue that has certainly come to maturity in the commercial market. I've been hearing a lot more conversations around it, just to say, do we have enough safeguards? Do we understand how telehealth is being utilized? Do we understand who's using it? Do we make sure that our state laws allow insurance companies to have the review process that they would have for in-person visits? And I think as we've worked in probably about 24 states now on telehealth, there's been this recognition that, okay, we want to make sure that we revisit this now, and then we probably need to revisit again in the future as we learn more, as research becomes more apparent. So huge upside for patients, big upside for providers, but definitely an issue that it's not a one and done and we can walk away. We do have to continue to monitor it and tweak the rules and regulations to make sure not only the innovation is allowed, but also that we're not just feeding bad apples that do exist in the system, and that we're actually getting value every time we interact with the healthcare system.
You mentioned that you've worked in a couple dozen states, as we are the Show Me state. Is there someone who's the gold standard right now? Who should be the model?
Well, that's a complicated one to answer because everybody does have a little bit of caveats. I think, from our perspective, and this is just from our organizations, we have focused on two primary areas in telehealth. The first one is to open the door to a more cross-state line telehealth, because we think that's really important given the shortages. And I took a peek in your state of 114 counties, almost every single one has provider shortages for dentists, for mental health providers, for primary care providers, literally almost every single county. And so I think there's just a recognition that we can't keep our head in the sand any longer. We need to increase access. The other one is just making sure that other providers can utilize the services. Some states, it's been very physician-centric, and only doctors can utilize the services. And so, again, I think there's been a growing recognition we need to allow, to Naomi's point, nurse practitioners and others to make sure that they can utilize these technologies going forward. I'll just wrap up by saying I think there's a couple states that are probably on some of these, those 2 points in particular are a little bit farther along. Florida has passed relatively recent reform allowing out-of-state providers to register in the state, making it much easier. New Mexico's across state line laws are pretty good. Minnesota are pretty decent. And I will turn it over to Naomi because I do think that there has been some really encouraging activity in Arizona and in Idaho that are moving in this direction.
Yeah, sure. Go ahead, Naomi.
So I'm really excited, enthusiastic about a current bill that's running through the state legislature in Arizona. And it's really very similar to the universal recognition bill, but it applies to telemedicine. It covers all providers. And it really is, I think, going to be the next big thing in telemedicine as far as what states can do to really open up telemedicine for patients who are in rural areas, for example, or even urban areas, but especially patients in the rural areas and those hospital facilities that cannot afford to hire high-level expertise in a wide variety of specialty areas. It's going to transform the way healthcare is delivered in this country. That is my belief. Now, I do want to talk very briefly, when we talk about telemedicine, there are absolutely concerns about fraud. There is fraud in healthcare. That is not going to go away, and it will continue under any kind, as long as we have this current dysfunctional third-party payment system, we are going to have continued fraud. And it's just a fact. And so we're very cognizant of that, and we are working to make sure that this issue is constantly evaluated. It's a real concern, and the taxpayers who fit the bill for the public programs really have an especially vested interest in this. So when we talk about, I want to be very clear that when we talk about healthcare spending, in many cases, we're talking about the cost of a service versus the utilization of a service. When we talk about healthcare costs, we need to be very careful and precise about what exactly we are talking about. For example, with telemedicine, it is very possible to deliver a service for a particular service at a much lower cost. But if you have more access, you might actually have more people getting that same service, which increases the utilization and the overall spending. So I just want to make sure that we're really clear about what it is we're talking about and being very precise. When we talk about scope of practice, when we talk about telemedicine, these terms are thrown around, and the cost of a service has a specific meaning, and the utilization and spending is a little bit different too. So we just need to be very careful about that. And I do acknowledge that when you make healthcare more accessible, people will use it more if they need it. And so more spending for a particular service isn't necessarily a bad thing if you're preventing future problems down the road, if that person is going to live a healthier, more productive life. And so the way that we budget healthcare through governments makes it difficult to take a longer view. Private employers, especially those who are self-insured, are able to do that much more easily. but those people that are dealing with year-to-year budgets where they are required by law to balance the books don't have that luxury. So that is a real concern as well. So we've talked a lot also in telemedicine about parity. And I just want to address this very quickly because in the Arizona bill, there isn't what I would necessarily call a parity provision, but there is a provision that says that insurers cannot pay less for the telemedicine service. This is really, I think, important. I need to explain, just that in the stakeholder process, this was an essential component. It's not one that I love or am particularly enthusiastic about, but it is important to acknowledge that there are upfront IT infrastructure costs that, absent permanency from Medicare flexibilities on telemedicine, you are not going to see the large-scale investments in telemedicine without a provision like this. This is what we found out through the stakeholder process over the last few months. It's something that hospitals are now on board with this particular bill because that is in place. And we also believe very strongly that over time, that the prices for these services will be ratcheted down by the insurers negotiating. There's no rule that says that they can't pay less for the service. So we think that over time, for a lot of these services, you will see a decline in the actual cost of the service because they still have that flexibility there. But like I said before, that there is no silver bullet to telemedicine. This is something that is a bold, innovative reform. It is going to, I think, be 95% right on target. And for the rest, we're going to have to go back and revise over time. But the bottom line is that this particular reform is going to change the way healthcare is delivered because it will be allowing us to really harness the potential and capacity of telemedicine, as well as things like phone consultations for those in rural areas that don't have broadband, for example. But it's really going to change the way we think about healthcare and the way people are actually receiving it.
Ray, two-part question for you. First, I'm going to ask you to prognosticate on what do you think the chances are that the individual mandate on insurance is reinstated? And the second part of the question, what would the introduction of a public option do to the insurance environment and specifically premiums?
Yeah, so I think that there's a very little chance that the individual mandate is going to come back for two reasons. One is it's not popular, right? I mean, we just simply politically speaking, it's not very popular. The second thing is it didn't have much of an impact. So, I mean, basically, it's a lot of political pain for not a lot of gain. The fact of the matter is the Congressional Budget Office estimated that millions of people would go uninsured with the individual mandate. When the individual mandate ended in 2017, we did not see people uninsured flooding the streets because suddenly they were no longer required to buy health insurance. Instead, what we saw is insurance companies adjusted. They changed the way that premiums basically gets a little bit more subsidies from the federal government, for example, through silver loading. And so at the end of the day, the individual mandate simply didn't have a huge impact on the take-up rate of health insurance. And so as a consequence, people in Washington have changed their expectations on what the individual mandate will do going forward. Unfortunately, it's a little late for those of us who are fighting for repeal of the ACA. Because you were hearing all these stories about if Republicans repealed the Affordable Care Act, there'd be a huge spike of uninsurance. Well, that turned out to be false, and we were right. But so, Zach, I have very little belief right now that Democrats will take this on because there's a lot of political pain with very little gain. Instead, again, what they're looking at is literally throwing billions of dollars at the problem. Increasing the subsidies through the ACA, giving people a lot more money to buy more expensive projects. And that's what we're seeing right now in the Biden playbook.
Great. All right, Patrick, to you, our Missouri expert. So we're talking about making all these reforms permanent. How do you feel right now about that possibility for Missouri specifically? And what do you think the biggest hurdles that we have to get through to make these reforms permanent?
Well, I'm really optimistic. I mean, I think we've seen legislation already filed in both the state House and state Senate that would deal with some of the scope of practice issues that we've already talked about, telemedicine as well, going from an in-person kind of initiating visit to just a kind of an online questionnaire as to make sure the doctors know exactly what the patient's needs are ahead of time, so you don't have this physical meeting that's going to be required. So I think that the legislature is inclined to adopt a lot of the reforms that we've talked about for a long, long time. I mean, certainly, just like in Arizona, Missouri passed an interstate license reciprocity bill that not only, touched on healthcare workers, but all sorts of licensed professions. So I think that the sensibility of the legislature is toward more freedom, toward greater freedom, toward more reliance on a market that actually, puts downward pressure on prices and puts upward pressure on access, allows for more people to access more services at a lower price. And so I'm optimistic. I think that now is kind of the prime time for the legislature to take action on this. Certainly we would have wanted to have seen these reforms happen, years ago. But I think that the legislature in Missouri, I think legislatures across the country and governors across the country recognized pretty immediately last year that a lot of the things that all the experts on this panel have been talking about for years, that was the right way forward. And I think that the rollout of these reforms, whether you're talking about scope of practice or licensing or telemedicine or even short-term health insurance or the insurance programs themselves, that in some cases you're talking about reducing mandates and making sure that people can gain access to these products. I think that the last year has been a positive one for free market reformers. And I think in Missouri in particular, I think the legislature is inclined to adopt a lot of these ideas and reforms. Again, they've already been filed in both chambers. And certainly, I think improvements can always be made to these laws or these proposals. But I think we're a lot closer to a better system for our healthcare here in the state than we were certainly 18 months ago.
All right, well, we have come to the end of our time. So I want to thank all of our panelists for joining us. I want to thank all of our listeners and viewers for joining us as well. And I'll turn it back over to Brenda Talent.
Thank you, Zach. And I want to echo your thanks. Thanks to our panelists. What an informative program. Thanks to everyone for joining us. And I hope that you'll put us on your calendar for March 18th at noon. We're going to have another virtual town hall with Lee Habib. He's the CEO and founder of American Private Radio and host of Our American Stories, as we're going to discuss the power of storytelling, connecting policy with people. So to learn more about it, visit showmeinstitute.org. And thank you again for joining us, and stay safe.